In cardiology, I feel like, Ankur, we are doers, right? Even if I'm a general cardiologist, when a patient comes to my clinic, I want to do something for them to help them, right? So we are all wired that way. So, I could totally see why people were having difficulty digesting the results. But at the end of the day, you respect the data, you respect what is done very well in this trial.
You're listening to Parallax from Radcliffe Cardiology in association with makeadent.org. Here is your host, Ankur Kalra, MD.
Hello, everyone. Welcome to another episode of Parallax. This is a wrap-up of European Society of Cardiology Congress from this year. And, like every year, it's action-packed for cardiology. And, I certainly believe it's the best cardiology conference for each of us. And we did an episode last year with Dr. Parwani, which actually ended up being one of the most downloaded episodes from season 3 and was very well received by everyone around the globe. And, this year we are actually back by popular demand. We have Dr. Parwani again with us on the show. It's a name in cardiovascular medicine and within cardiology, which, in my opinion, requires no introduction. But for those of you who do not know Dr. Parwani, she is a cardiologist and assistant professor of medicine at Loma University in California. And she was actually in Barcelona for the Congress and did a phenomenal coverage on Twitter for all of us who were not able to join in person. So with that introduction, Purvi, welcome on the show. And thank you so much for doing this for us again this year.
Thank you, Ankur. Always a pleasure to be back. And ESC was a lot of fun, like always, this year as well. And I was delighted to be there as a faculty after 2 years. So I'm glad that I can bring those bits and pieces to this audience who appreciated us a lot last year. So hopefully we have another successful episode this time around as well.
Yeah, no, absolutely. I wish the same. So we're just going to jump in right away because we have quite a bit of material to cover. And I'm going to start asking you about Revived, which, as you said, there was a pin drop silence in the audience when this was being presented. The results were being presented. And it sort of is, time for all of us to, take a pause, digest what the findings of the trial were, and, take note of one's own practice. But I'll have you share your thoughts and, also the findings of the study. Just for the introduction, this is a trial which is trying to address revascularization in patients with ischemic cardiomyopathy with low left ventricular systolic function, so ejection fraction less than 35%. And, from my understanding, most of these patients did not have angina. So I'll stop here and I'll let you pick up and tell us more about the trial.
Thank you, Ankur. So Revive stands for the revascularization for ischemic ventricular dysfunction. And as you mentioned, when the trial was presented and as those Kaplan-Meier curves went on the screen, there was an audible pause, like there was an awe. And both sides of me were 2 interventional cardiologists from some different countries that I did not know about. And you should have seen their reaction. And I was just noticing how people were reacting. And I think the bigger surprise for me came later when, we digested this on Twitter, and it continues to get more and more attention. But just for the listeners, so this was the trial that had LVEF of less than 35%, extensive CAD. Some of us, have seen those cases, the Revive cases at TCT. It was also posted on Twitter. So check it out, how bad the CAD was. And this CAD was randomized to multi-vessel PCI versus optimal medical therapy. So total, they enrolled around 700 patients. Trial took almost 7 years to recruit and 8 years to complete. Their follow-up, the mean follow-up was around 3.4% Again, poor percentage of women represented, only 13%, and almost 40% of these patients were diabetics. So, what a setup, right? To me, this trial was designed perfectly in favor of interventional cardiology to succeed, right? So a perfect setup for success. They take multivessel disease, they find a viable myocardium, and I actually went into the supplements of the paper and looked up their definitions of viability. So they did not even mess around. As viability on CMR, it's not a dichotomous variable. So they only took patients less than 25% of the scar, so really not that much of burden. And they needed, for the trial inclusion criteria, viability was needed in more than 4 dysfunctional myocardial segments. So, of course, as you mentioned, 66% of these patients did not have any angina. 32% had either CCS class 1 or class 2 angina. More importantly, 77% of the patients were NYHA class 1 or 2, and 23% of NYHA class 3 and 4. So I can tell you that in my general cardiology clinic, I do see these patients predominantly asymptomatic, come with LV dysfunction on the echo. There is multivessel CAD, and what do we do after that, right? So the primary outcome was all-cause mortality or hospitalization for heart failure, which occurred in almost 37% in PCI group, 38% in the GDMT group, and the findings were consistent across all the subgroups. So, if you look at the trial, it was a clear negative trial, but if we look at the quality of life analysis, the KCCQ overall summary score, that did favor PCI at 6 months and at 12 months, but at 24 months, this, benefit was nullified. So, if we look at this trial overall, again, the first trial to include left main patients, most of the times in our CAT conference, at least, we hear this often, or left main, there's no studies with left main. We need to protect the patient. We need to give survival benefit. So this trial did have 14% left main patients in PCI arm, 13% in GDMT arms. And again, as I said, in none of the subgroups, there was any benefit. 50% of the patients had 2-vessel disease, and 38% of the patients had 3-vessel disease. So one of the criticism on the Twitter, at least, that I saw was how many patients had complete revascularization. And I think the lead discussant and the presenter had discussed this. So anatomical revascularization index, the mean index was around 71%. So in 71% of the patient, complete revascularization was achieved. Yet, PCI did not show any benefit. So to me, when I look at this trial, this kind of joins all those negative trials for PCI that we have seen. To me, when I apply this to my clinical patient that comes to my clinic, I would say that if any patients come with ischemic cardiomyopathy, triple vessel disease, and if they are symptomatic, I think our first duty is respect STITCH trial data and try to see if they're a CABG candidate. And if they are not a candidate, then perhaps, get them on as much GDMT as you could and reassess them and see if they remain symptomatic. And if you cannot pin down those symptoms to heart failure, and if you think it is truly anginal symptoms, then have that discussion with patients, tell them that, we can make them feel better, even if the, outcomes may not be better by doing a PCI.
Yeah, no, excellent discussion, Purvi, and I was, like you said, Twitter was on fire when this was being presented. And, thanks for, again, an excellent coverage of the trial on Twitter as you were digesting the results yourself in Barcelona. And there were discussants on Twitter, who actually said, well, do we really see these patients? And, we actually do. I agree with you. We see these patients all the time. And I think, personally for me, eyes have been rolled in conferences when I've actually stood up and said, look, we're trying to extrapolate CABG results from STITCH to PCI, but there isn't a trial for revascularization utilizing PCI as the revascularization option in patients with ischemic left ventricular systolic dysfunction. So we are taking a leap of faith here and extrapolating results from STITCH, and STITCH, the sub-study or the arm which actually looked at viability, really. Viability didn't have any role to play whether or not these patients ended up doing better. I think the results for STITCH were, true regardless of the status of their viability test, which, again, for me as a clinician brings viability into question. But to your point, a trial which was, designed for success of PCI and interventional cardiology, you have multivessel disease, you have ischemic LV systolic dysfunction, these patients are diabetic. There is viability, which is showing viable myocardium. I mean, what else do you need, right, to really, sort of stand up and say, look, I'm going to revascularize this patient. This patient is going to have benefit from revascularization. And, here we are with just overlapping Kaplan-Meier curves, as you pointed out. One question I have for you is, do you, I certainly have to look at this myself, but my assumption is that there was not even a difference in the delta improvement in LV ejection fraction.
Yes. I actually didn't mention that, but yeah. So if we look at the subgroups, the LVEF, I think at 12 months, it was like literally 0.9% point different, 1% different between the two, which is, you just get surprised, right? Because we are all, in cardiology, I feel like, Ankur, we are doers, right? Even if I'm a general cardiologist, when a patient comes to my clinic, I want to do something for them to help them, right? So we are all wired that way. So, I could totally see why people were having difficulty digesting the results. But at the end of the day, you respect the data, you respect what is done very well in this trial. And you're absolutely right. Not much difference at all, like 1% difference in LVEF. And to be honest with you, reading echoes for so many years now, I have seen all those patients Impella guided, high risk PCI come back and there is no benefit at all. And you always question yourself, right? Like, why did this patient not improve? Because this myocardium did look okay before they went in. But I feel like all those loose threads were kind of tied by this trial. It clearly gave us some answers. And I guess, a lot of people made the comment about, oh, was it bystander CAD? But I can tell you, reading CMRs again for years, CMR is a very sensitive tool. And, it will tell you if there is any, and, this CMR, I think the core lab was in UK, and that UK has way high number of CMR usage. And, it's a very well-known leading CMR cardiologist who was leading the core lab. So I have no doubt that, they did their due diligence. Patients were selected, very, very efficiently, by doing a viability testing in the best center where the CMR is done all the time. So like, to me, there's like, I don't see anything why we should doubt, these results. And, do we challenge the whole hypothesis of hibernating myocardium? I keep going back and forth. And at least in the CMR world, one of the arguments I'll tell you that was brought up is, does the viable myocardium make the tissue more successful even to GDMT. And maybe that's why the GDMT was so much better that, PCI did not even make a difference. And that's something that I don't know. I don't know if this trial was not designed to test the viability. So again, we don't know, whether the GDMT arm could have been different. Like, is there a possibility that non-viable myocardium, the GDMT, may not do that much better? I don't know the answer to that. To me, it is still unlikely, but these are the questions that we are answering. And, to me, we are thinking, we are following the data, and that to me is the biggest victory. And this is why I love being in cardiology, because we test ourselves every time there is not an answer. We test ourselves, whatever the result may be. I think we should accept it and, move along now with these results.
Yeah, no, I mean, more power to guideline-directed medical therapy, now with the quadruple backbone, with MRAs and SGLT2s and beta blockers and ARNIs, certainly that's the way to go. And I would certainly consider that, on top of course, if it's, incident coronary disease and there's ischemic cardiomyopathy, you would give aspirin and a statin and then actually see how these patients do. But, really ironclad in terms of its design, in terms of its execution, in terms of objective documentation of multi-vessel disease and also viability. What a way to randomize and even follow up. I mean, the follow-up is not short, as you mentioned. So you really, I think practice informing, practice changing, very well conducted. Congratulations to the investigators. It certainly goes down as one of the landmark trials in cardiovascular medicine. Great discussion. And, I'm sure we're going to continue our debate on this in the meetings to come. Moving along, the second one that you've picked for the discussion is DANCAVAS. And again, important study. It's a population-based cohort study, actually a randomized design. And this one basically talks about screening, population-based screening for cardiovascular disease, and whether or not it has any effect on the risk of death. So I'll have you take it from here and tell us more about this study.
Yeah, so another trial that described, as you mentioned, 5 years outcomes of the Danish cardiovascular screening. Very well executed, I must say, when you look at the study design, although they are not in my good books because they didn't enroll any women. So we'll talk about that at the end. But I think that when you look at the study design, it's truly impressive what they did. So we know that Denmark, is very well advanced when it comes to healthcare system and what they have. So this was a screening trial. They took 46,000 men between age 65 to 74. 1/3 of them got screening, 2/3 got standard routine care. And the screening was seriously comprehensive. They took one non-contrast CT. On that non-contrast CT, they determined patients' calcium score, coronary artery calcium score, and also detected if there are any aneurysm. And, by the way, the CT was read by technologists, I'm assuming to minimize the cost. And then when these patients came for their SCAG scoring, they also took a snapshot of their rhythm to detect any atrial fibrillation. They took their blood pressure to detect hypertension and ankle brachial blood pressure measurements to see if they have hypertension or if they have peripheral artery disease. They took a blood sample to detect any diabetes mellitus or what the cholesterol numbers, if they had any hypercholesteremia. And everything was done in a super efficient manner in less than 40 minutes. Then they followed these patients for 5.6 years. The primary outcome was death from any cause, which is reasonable given that this was a screening strategy that they were testing. So after 5.6 years, 12.6% in the screening group and 13% in the control group had died, and there was no significant reduction in the primary outcome. So the hazard ratio was 0.95 and the confidence interval was 0.9 to 1. based on which the lead investigators said that maybe there is a possibility of benefit, because there is that 10-point difference in the confidence interval. But nonetheless, they did a pre-specified analysis in men between 65 to 70. So the trial was done between 65 to 75. They took men between 65 to 70, and in that pre-specified analysis, there was 11% reduction in the primary outcome. So, of course, with any of these screening strategies, particularly when you use CT, we have seen greater uptake of antiplatelet and lipid-lowering medicine in the prior CT trials, and that was the same here as well. There was larger use of statins, of aspirin in that screening arm, but there was no difference when they looked at the antihypertensive, any diabetic medicine, any coronary or aortic revascularization, or any anticoagulant use, because they also screened for AFib. So then, since it was a screening arm, they also did a cost-effective analysis. And I think if we look in the US dollars, I think the healthcare cost per person was around $206. And the quality-adjusted life year statistics were probably comparable to the breast cancer screening. So, very well done study particularly for cardiovascular preventive strategy. It was negative, and there are some criticisms. So number one thing is that, is it really optimal age to do screening? We know that atherosclerosis starts when we are born, and it's a continuous process. So one can argue that is it really the optimal age if we want to prevent cardiovascular disease? I would say probably no, looking at the patients that I see. The second thing is that although there was, they did the calcium score, there was no comparator arm, right? And that has been the criticism for any CAC studies so far published, that there is no randomized control trial, there is no comparator arm for calcium score. So we have CT data from the coronary CT world to show that the screening improves and these patients take more statin. So one can argue, which has always been a criticism, at least on Twitter, that I have seen, that should we just like stick to the goals, which is our goal is to put patients on statin, and if they qualify for aspirin, we should put them on aspirin. Why do additional testing to do that? Now, I tell you, I use calcium score quite a bit in my clinical practice. And every time patients see that calcium and you explain them what exactly that means when it is in coronary artery, I'm biased because I have seen better compliance, when it comes to patient population. And, we have Scott Hart to show that these patients did do better. But the question is, this was Danish study, and Denmark is a small country with a very solid healthcare system. When you take any other country with not so solid healthcare system, is it really, feasible to do this kind of societal screening? Also, they did not take any women at all, and I'm very upset about it. And there was, a lot of discussion at ESC about this, and a lot of lead investigators raised some serious ethical concern about this. In fact, the discussant, called out this, and one can, we can really think about why these funding agencies for these kind of huge studies are giving the money for the studies that do not enroll women at all, when we know that atherosclerotic cardiovascular disease still remains number one cause for death in women as well. So that's the thing. I don't know if this trial will apply to other countries. I don't know if it will apply to 50% of the population, which is women. I don't know if it would apply to non-white people. So apart from that, I commend the investigators for the comprehensive screening tools and how they conducted the trial and how efficient they were in doing the screening as well as in following up with the patients. But it still remains to be answered what exactly is the optimal screening strategy for our cardiac patients.
So again, an important study, like you mentioned, and screening is something which comes up routinely for us, whether we're seeing patients in clinic, whether we have friends who have parents who are in the age group and need screening, right? Or, whether we have neighbors who, happen to know a neighbor cardiologist and want to run some screening tests by which, some of their executive health checkups, conducted for them. So it's relevant, again, it's something that I need to sit down with and really ponder as to, how do we offer screening, or should we offer screening at all? And at what age should we start screening? And, it's beyond me, quite frankly, to see a trial of this scale, with that, again, ironclad methodology which decided to, not include women. When both you and I know that the burden of cardiovascular disease and atherosclerosis is shared equally with women. It just befuddles me that we still have a trial like this in 2022, but here we are, and this is such a well-conducted study. But, barring that, like you mentioned, again, excellent tools utilized for screening. So ankle brake index for peripheral arterial disease, GAC score. Then they looked at hypercholesterolemia diabetes. So fairly comprehensive, and, AFib and aneurysms also, which, the guidelines, and, correct me if I'm wrong, but the guidelines is that anyone with a history of smoking over 65 gets an ultrasound for an aneurysm screen, right? Yeah. So, and then you have sort of people in the same age group. Now, I don't know what percentage of these were smokers. I'll have to look into the data shelves myself. But again, to then come out and say, we screened this population, and the numbers they're not trivial. These are fairly large numbers. And the follow-up is excellent. 5 years is not a small amount of time. To then say that, there was not a difference in all-cause death is, again, very similar to the first study that we discussed. One would just take a pause and really ponder and ask questions. What are we supposed to do? Are we supposed to offer screening? Because, I'm sure you see these patients in your clinic too. It's just a cardiology wellness exam. I have a family history of premature atherosclerosis, or I have a family history of heart disease. And more often than not, that family history isn't really true family history, with onset, in men less than 45 and in women less than 55. It's sort of in the 60s. And then you're sort of like, okay, we could do a calcium score. But then if you now have this study, how does that change your practice, Purvi?
Quite frankly, it doesn't, Ankur. And I'll tell you why, because I told you that, this study does not apply to many cases that we see, in our clinic. And I think that this study, if anything, so look at the, contrast, right? You have revived shows, I was telling this to my fellows, and it kind of, when I did, as you say, introspection on my flight and stuff about what science had been presented at ESC, it's so mind-blowing. On one side, you have repeated studies to show that, doing secondary treatment doesn't work. GDMT works, and atherosclerosis is bad, and we know that there was PCSK9 data presented as well, right? So prevention of atherosclerosis is good, but treatment of atherosclerosis somehow does not make any difference, right? So prevention to me is very, very important, and I would not technically disregard this study completely, because as I told you, that those confidence interval were quite, there was like that 10-point difference, and there was benefit in the 65 to 70. But what the questions I have is, prevention is good, and we know we all ought to do prevention regardless of what cardiology subspecialty we belong to. But which is the population where we do, the screening is the question that remains, right? I think recently the Miami heart study was published, that looked at the prevalence of atherosclerosis. And almost 50% of the patients, asymptomatic patients, have atherosclerosis. And, that doesn't surprise us, right? So screening is good. At what point the screening should go on, I don't know. I don't think that this study showed us the positive outcome where we can take that and start screening our 60-year-old patient. So I don't know. To me, prevention remains the most important now, particularly now that everything else kind of is, going out of favor, right? Prevention is the most important thing to me in cardiology in this day and age. So what population we target, and the other thing that comes to me as I was at ESC, which was another mind-blowing thought. I heard Dr. Fuster say this somewhere, that there is a constant tension we have in cardiology between precision medicine and simplicity, right? So do you take global health and decide to do prevention, screening, CAC scoring, which is very crude way to look at atherosclerosis, or do you take those patients? We all have heard those South Asian men. I lost my friend, last year, suddenly very healthy, and we all have those examples, right, where people are lost suddenly. So do we take those crude measures of screening, or do we go with precision medicine and decide to see? And that's a tension that remains even in my mind. When I see a patient, what is the best strategy to provide treat the diagnostics to that patient so that we can treat them early enough where they do not get any manifested coronary artery disease.
Yeah, no, I think you raise an important question there. That was a really good comment, and that is, at what point do you actually start screening? I think that is the bigger question. And again, prevention is the way to go. I mean, I'm a huge proponent and a practitioner of prevention myself, and I completely believe in prevention. The question really to me is, after this trial particularly, is it really moot to even offer screening at that age, like you said at the beginning of the discussion? And really, at what age should we start screening? And South Asians, of course, there's a heightened risk for atherosclerosis. The onset is earlier, but we don't have that kind of study specifically in South Asians, and maybe we should. But again, important study, relevant data. Thanks for bringing the pitfalls to the fore, for the listenership, and again, practice informing. So moving along, the next one that you've picked for discussion is deliver. So we're back to discussing SGLT2s. This time in patients with HFmrEF, which is mildly reduced ejection fraction. And this trial also included patients with HFpEF, which is preserved ejection fraction. So you want to talk to us about this trial?
Yes, and I should disclose that I have received some funding. I'm a speaker for AstraZeneca for DAPA. So with that disclosure, I think that the SGLT2 inhibitors have, it's the medicine that keeps on giving. So this result for deliver was already known since May, but it was nice to see all the details at ESC. So this was dapagliflozin and heart failure in mildly reduced or preserved ejection fraction, as you mentioned. 11 manuscripts on that same day with different papers combining deliver and some of the other EMPA trials. But in this trial, they took 6,200 patients with mean age of 72 years, 44% women, 10 milligrams daily dapagliflozin versus a placebo on top of the usual therapy. Patients were followed for 2.3 years. And, during which time dapagliflozin reduced the rate of cardiovascular death or worsening heart failure with a number needed to treat of 32. So again, the results demonstrated significant reduction in primary composite outcomes of cardiovascular death or worsening heart failure. The rate was 16.4% amongst the patients that were mildly reduced or preserved EF versus 19.5% in the patients that received placebo. So the most important finding here I want our listeners to note is that LVEF did not influence the results by any means. And as I remember, as the discussant said there multiple times, that there is a remarkable consistency that we see when it comes to SGLT2 inhibitors, but particularly with dapagliflozin in this trial with every pre-specified subgroup. So, the effect of the medicine did not differ between the patients that had ejection fraction above or below 60%. Why this is important is because Emperor Preserve trial that was done with empagliflozin had decreasing benefit with higher end of LVEF. So, this trial again, supported SGLT2 inhibitors, regardless of EF, age, gender, or presence of diabetes mellitus. And I think that the discussant mentioned that these results will definitely impact the guidelines, and perhaps they'll come up with another update for the guidelines. And because right now the SGLT2 inhibitors is a class 2A for heart failure preserved EF. And at least there was some discussion that hopefully this will make it class 1. So why it is important to, again and again notice this difference is because most medicine like Entresto or Aldactone have benefit with heart failure, mildly reduced EF 40 to 49%, but not with the true heart failure preserved EF. So truly a win for our patients. We all have seen those patients. They keep coming back to hospitals, and this clearly reduced, heart failure hospitalization as well. Few important things to remember here is that, as you know, heart failure preserved EF can have cardiomyopathies, and those cardiomyopathies, if they were diagnosed, were excluded. So this was heart failure preserved EF, but no presence of any sort of cardiomyopathy. The other thing that we need to remember is that, our patients, I practice in, Inland Empire, which is unfortunately the most, one of the most low socioeconomical class neighborhood in California. And, how many of my patients are able to afford DAPA or EMPA? I mean, I'll tell you that not many, right? So it's still a struggle how many patients can afford it. And that's to me, it really hurts me when you have a medicine like this, you have Entresto, you have dapagliflozin, empagliflozin, but then at the end of the day, the patients cannot afford it. That truly hurts me that there's something out there. It kind of reminds me of being back home in India. That was probably one of the main reasons why I left India and came to United States, because to me it was, my heart would get heavy when I would see these patients who deserved therapies and did not get it. So this is an ongoing struggle that we all have to, answer at some point, and hopefully, these pharmaceutical companies will help us. The other important thing is to remember is that effect of this medicine was apparent within few weeks or months. They also included the patients who were hospitalized. And so I think that very confidently I can say that as soon as you see a patient with heart failure, regardless of what the EF is, regardless of whether you get the echo or not on the same day, you can probably start that patient on SGLT2 inhibitors if other contraindications for medicine are not there. So again, remarkable study, remarkable trial, practice informing trial, win for our patients, but we'll see, how many of our patients can afford it.
Yes, excellent discussion there. I couldn't agree with you more that cost remains the biggest deterrent for us to prescribe this medication, for patients. And, after all these years and after all these trials, we finally have a class of drugs which has shown benefit in a very challenging population. I mean, 50% of heart failure patients have heart failure with preserved ejection fraction. So it's a sizable cohort of patients that we see. And, for years on end, there was one trial after the other with a multitude of agents, and none of these medications showed benefit. You finally have a class which is showing benefit, with Emperor preserved and now deliver. It's just, again, I agree with you, heartbreaking that you would not prescribe this drug for cost being a deterrent. So, something needs to be done about it. Absolutely. I don't know what, I don't know how. That just remains a constant struggle, even in the United States, unfortunately. But again, important trial. And I think for just the practical purposes, what is, when you see these patients in clinic, Purvi, and in patients who can afford the drug, what is your starting regimen in terms of dose? And then what do you do just practically? How do you follow these patients in clinic in terms of getting any blood work done or any testing done, and asking them any particular questions when it comes to tolerance?
Great question. So, the dose is the same, 10 milligrams per day. I think that the only contraindication that I truly follow is if they are on hemodialysis or if the GFR is less than 25. That's when I think there are physicians who would tell you that they use it between even 15 to 25. But if you look at their package insert, I think GFR 25 remains less than GFR 25. It is not recommended. I particularly for, DAPA or EMPA, I tell you that I haven't done much blood work, but generally, now the recommendation, at least for heart failure, is that start aggressively, 3 class of medicine together, if you can, and it's not gonna, hurt the patients. So I do that. And when I have Entresto on board or, Aldactone on board, then I would check their, Chem7, in a week, and in day 3 and in a week, as the recommendation says, but not particularly just for, DAPA or EMPA. I would always instruct the patient about the UTI risk, because as you know, particularly with women, I think the female anatomy has been associated for, with more UTIs in these drugs. And I have patients who I have, I had to take them off SGLT2 inhibitors. So if you look at, again, the package insert, they say that just regular hygiene should prevent the recurrent UTI. And you should just instruct the patients not to, basically just to take care of their personal hygiene. But I have probably 3 or 4 examples where that has not worked, and patients, cannot take this medicine. So those are the things that I discuss.
Yeah, no, good points. And, just for the listenership again, and I ask these questions to you specifically because there's a lot of inertia. In experience, there's a lot of inertia even with all these data coming out for this drug class. I see cardiologists having a lot of inertia in prescribing SGLT2s for some reason. These are questions which are just practical, points so that we can help our colleagues to somehow mitigate that inertia and get on board in prescribing these drugs. Typically, you said that you would be comfortable starting early on and with aggressive therapy as backbone, which I completely agree with. Which agents do you typically pick? You typically pick a beta blocker, an MRA, and an SGLT2, and then add an ARNI. How do you go about doing that?
I do. I mean, there are papers written about it, and I hope that no heart failure cardiologist is listening, and I hope they don't punish me if I say something wrong. But I do beta blockers, Entresto, and SGLT2 inhibitors together with spironolactone or aldactone. I just want to see with Entresto what the potassium and creatinine is first before I start the aldactone. So that's how I do it. So I'll bring them back in follow-up. at a short interval in 1 month or so. And then at that time, I'd review all their, the lab data. And then I would see if they're appropriate for aldactone as far as blood pressure is concerned, as far as potassium and creatinine is concerned, or any other contraindication that may come up.
All right. Excellent. No, again, for anyone and everyone who's listening, SGLT2s are revolutionary for our patients and are life-saving therapies for a challenging population. And, we all encourage that you should get on board and start prescribing these medications. Of course, we know cost containment is an issue, but if that is not an issue, then these patients should not be left alone in terms of having access to this life-saving therapy. So moving on, Secure. A randomized trial for a polypill, which contained aspirin, an ACE inhibitor, and a statin. So do you want to tell us about that, Purvi?
Yeah. So Secure was a secondary prevention of cardiovascular disease in elderly trial. So this was a secondary prevention trial. So again, another, very smartly picked group. They took 2,500 patients, 31% of women, predominantly older patient, mean age of 76, that had MI, myocardial infarction, in previous 6 months. So we know that these are the patients that are extremely high risk, right? They have had MI, and these are the patients where GDMT would completely play a very important role in reducing their future risk and the present risk if the patients take GDMT. So of course, to me, this trial was designed for success, right? Because we know that at least in United States, when not only the compliance is an issue when you prescribe, 3-4 different medicine to the patients, whether it is MI or heart failure, but also with every pill a patient that you prescribe, a patient has to pay the copay, right? So if you can somehow combine and give them this polypill, you can achieve, of course, better compliance and hopefully reduced cost, and more patients can afford it, more patients afford it, more take it. So really nicely, selected patient group with MI in last 6 months. In the baseline group, the blood pressure, the systolic blood pressure was 129. The LDL was 89 milligrams per deciliter, which I would argue is quite good for patients that just had MI, because none of my patients that had MI come with those kind of numbers. But nonetheless, polypill included aspirin 100, ramipril 2.5, 5, and 10. So 3 doses for ramipril, and atorvastatin 20 or 40. So 41% of the patients had ramipril 2.5, atorvastatin 40, and aspirin 100. Almost 92% of the patients received the higher dose of statin, which is 40 milligrams atorvastatin. 80% were also on beta blocker. And, 95% of the patients in both polypill as well as the usual care arm already had additional antiplatelet agent, which is understandable given that they just had an MI. So the 6-month adherence, as you can expect it was much better in the polypill arm, and it remained consistently well. The compliance was better even at 2 years. They followed these patients for 4 years. The primary outcome was cardiovascular death, MI, stroke, or any urgent revascularization, which happened 9.5% in polypill arm versus 12.7% in standard arm. And so basically 3.2% absolute risk reduction with 24% relative risk. So quite impressive number. So when you look at this trial, of course, it's an impressive trial, impressive result, except what was surprising though is that even though you have this significant difference in the outcomes, the systolic or the diastolic blood pressure numbers between the two arms at 2 years were not different. The mean LDL level was not different. And yet you have significantly lower risk of major cardiovascular outcomes in the polypill arm compared to usual arm. So the question is, what drove the difference? And, I think Dr. Fuster presented this trial, and he argued that it was the pleiotropic effect of the aspirin, statins and the ACE inhibitors, And then I think Salim Yusuf said that it was the use of aspirin, the polypill. But regardless of, these are just speculation, right? Can the pleiotropic effect be so big that you have 24% relative risk reduction? We ought to ask ourselves. But it's a positive trial, and nonetheless it worked in patients, so that's a win. Now, I must tell you that even if we look at the previous studies with aspirin, the benefit with aspirin usage in this particular population for secondary prevention hasn't been that big, 24% relative risk reduction. So whether to put that on aspirin or combination of pleiotropic effects plus aspirin remains to be understood. And there was a limitation that multiple people there pointed out was it was a bit underpowered, and that I think was because of the COVID pandemic that happened. And it was a bit biased because it was an open label design. The way I see this is that, for global reduction of cardiovascular health, polypill there have been multiple trials that we have seen with polypill. It works in primary prevention, and I think it's the way to go even for secondary prevention, because we all have been on the other side, of that scenario where we see patients who cannot afford medicine or who forget medicine because of XYZ reasons, and then they come back with, second event, which can be fatal in some cases or life-changing in other cases. So I think that regardless of, the criticism on how the results were driven, I think it's the way to go, for many countries and many populations across the world.
Yeah, no, again, a global trial too, right, Purvi? And my question to you is, how do you see its implementation in the US particularly? I remain skeptical of its implementation in the US. Because of a myriad of reasons we've discussed, earlier in the show. But do you really see this coming in the US? I highly doubt it.
No, I mean, the pharmaceutical lobby in US is quite strong, and, yeah, you're right. I didn't think about that, but there may be some challenges. But I think globally, this would be a blessing, right? And I do think that there are patients, definitely, there are patients in excess in the United States that would benefit from such a strategy, regardless of what the insurance coverage or pharmaceutical coverage would be. We all know that in the United States, our healthcare cost is through the roof. And particularly these kind of strategies would, bring it down. And, I tell you, I had an allergic reaction like last month, and I had to take pills for like 1 week, and it's really annoying to take pills. So I don't even blame our patients. I had to take multiple pills a day, and, I had gastritis and this and that. And I just had a new respect for our patients, where we tell them that, oh, take these 5 pills. And for us, it's easy to prescribe. But on the other side, there is, every patient is different. They have side effects. They cannot afford it. They get gastritis because they're taking, all these pills together. So I definitely think there is a market for this. Whether it would be successful or not, that is a question to be answered, particularly given the pharmaceutical lobbying in the United States. But we'll see.
Yeah, no, certainly for example, for a country like India, this is such a boon. And I'm certain that there are many countries, not only in the Southeast Asian or South Asian region or Asia at large, but also Africa and, South America, where, this strategy is going to work and patients are going to love it, and it's going to be prescribed widely. Polypill sort of has been in existence in the domestic Indian market even before there was a thing called polypill. You had these combinations of aspirin and clopidogrel, and I would always wonder, why don't we have such combination therapies in the US? And and on the contrary, you would have those combinations available in India, and prescribers prescribing them without actually having a trial like this. So global win. How implementable it is in the US, I think time alone will tell. Which brings us to our last trial. Again, a very global trial with global enrollment, and it's a particularly special one for me, and I'm glad you picked it, because the second author on the paper and the discussant who presented it is Karthik, who is a mentor and friend of mine from my alma mater in Delhi, the All India Institute. So a great day for him and for the All India Institute, and obviously for patients. And rheumatic heart disease, again, we don't see that quite often in the US. And with immigration now and with refugees, things may change, but still it is not a demographic we usually see in the US, but is very prevalent in India and Asia and Africa. So tell us about rheumatic heart disease associated AFib, or what should be valvular AFib. And just to refresh the memories of the listeners, most of the DOAC studies were conducted in patients with non-valvular AFib. So with that, preamble, I'm going to have you discuss the results of the trial.
Yeah. So INVICTUS it stands for Investigation of Rheumatic Atrial Fibrillation Treatment using Vitamin K Antagonist, Rivaroxaban or Aspirin studies. And, I'm so glad I picked this, because I didn't realize you had the connection with the discussant. But nonetheless, this trial showed that Rivaroxaban, it actually did not prevent any adverse cardiovascular events when amongst the patients that had rheumatic heart disease. So, rheumatic heart disease, as you said, Ankur, is very prevalent across the globe. I think we do see quite a bit in Southern California because of all the Hispanic population that we have, but 40 million patients around the world, mostly in low or middle income countries. And these patients come with the symptoms. Almost half of them would have atrial fibrillation, though that atrial fibrillation really brings on the symptom in half of these patients. When they are treated, they are, of course, the standard of care had been warfarin, which got tested with Rivaroxaban in this trial. But when they get treated with, warfarin, only 1/3 get the INR in that therapeutic range. So definitely a study that was needed, because hopefully with oral anticoagulants, the hope was that, you can kind of mitigate those challenges and get the patients, in a better kind of milieu when it came to anticoagulation. So the total number of patients enrolled were 4,500. Mean duration was around 3.1 years. So they enrolled patients from almost 24 countries. You ought to have rheumatic heart disease and atrial fibrillation, and also Chadwas score of at least 2, so more than 1, which is at least 2, mitral stenosis with a mitral valve area of less than 2 centimeters square, or an echocardiographic evidence of left atrial spontaneous echo contrast or left atrial thrombus. So you needed to have one of these criteria in addition to having rheumatic heart disease and atrial fibrillation. So very well, selected population again. For the primary outcomes, they had stroke, systemic embolism, MI, or death from vascular or unknown causes. There were 560 events in the Rivaroxaban treated patients and 446 events with the warfarin. So the hazard ratio was 1.25, with a confidence interval of 1.1 to 1.4. So what was very surprising is that Rivaroxaban actually, of course, failed to show any benefit, but it increased the risk of death by 23% and risk of stroke by 37%. There was no difference in risk of major fatal, life-threatening, or any clinically relevant non-major bleeding or intracranial hemorrhage. So, I fail to understand this, that the bleeding was not different, yet you had higher risk of death, 23% all-cause mortality, increased in Rivaroxaban arm. So very surprising there. And also the second surprise to me was that if you look at the drug discontinuation, it was actually more common in patients that were treated with Rivaroxaban. And actually 23% of the patients stopped the medicine before the completion of the trial compared to 6% in the warfarin therapy. So maybe, one can argue that maybe these patients were just used to being on warfarin and they didn't like this new pill that, I don't know, I'm just speculating here, but maybe that was the reason. And the other silver lining was that, even if when we look at the real world data of warfarin, we are always worried about, INR, right? Because I told you that only 1/3 of these patients have INR in the range that we want them to be. But with this trial, after enrollment, and that warfarin arm had the INR recorded, I think, in 56% of the patients at 6 months, 59% at 1 year, 65 at 2 years, 64 at 4 years. So consistent, good INR throughout the study, which is, to me, at least that's a good sign that these patients were actually taking it. Whether it was the effect of the trial, that probably needs to be discussed, but it was consistent, good INR in the group. So I guess what do we take home from this is, I don't think that we should be using any oral anticoagulants for patients that have rheumatic mitral stenosis, because somehow these patients are valvular AFib, in other words, because I think that the way probably the anticoagulation risk works for this patient is perhaps different, right, than the other patients with AFib that we see. So I think this data gave us a clear answer on that. We always wondered this. So again, another, practice informing trial, what not to do is as important as what to do. And this was another one of those trials, and hence we picked this. The exclusion criteria, I want to mention those mechanical valves were excluded with this trial. Dual antiplatelet was excluded, and GFR less than 15 was excluded. And as usual, pregnancy was excluded, which I would say that we do see these patients with rheumatic mitral stenosis, at least in Southern California. I have sizable patients, female patients with rheumatic mitral stenosis that want to be pregnant. So those patients were excluded. So, those probably would remain the same guidelines. Another thing, like we know, the rheumatic heart disease is more common in women. 72% of these patients for INVICTUS were actually women. So more prevalence. And so to me, I think that, again, this is a very important trial. It told us what not to do. And I'm glad that it shed a light that what we believed in was right. And warfarin will continue to be the standard of care for these patients.
Yeah, no, again, super trial, very important for the global burden of rheumatic heart disease patient population. And the other thing, Purvi, I think why discontinuation may have been more in the Riva group compared with the warfarin group, it could be cost. Because you have, certainly this statement is definitely true in India. I don't know about the rest of the world, but cost is something that patients, do ponder when they are put on DOACs in India. This has certainly been my experience in conversations that I've had with, friends and, even my father back home. The other reason, as you were speculating, is these patients were just very comfortable and had a routine with warfarin and didn't want to change for a newer drug. Also when, I'm not really sure how much of the discussion around bleeding and reversal agents happens, for example, in India, but, for whatever reason, it may be patient preference. These patients may not have wanted to be on Rivaroxaban compared with warfarin. But again, provocative data, important subgroup of patients, and will have an imminent and immediate impact in those who digest the results and start applying these results to their practice. And again, shout out to Karthik and to the All India Institute for doing such a fantastic job on a global scale in coming out with this study and the New England paper. So that actually wraps up. I know it's a longish episode compared to our usual episodes, but again, it's backed by popular demand. And Purvi, as usual, thanks for doing a fantastic job. Very well covered, very well presented. For everyone who's listening, we take feedback seriously. Please rate us and review us on Apple Podcasts, SoundCloud, Spotify, Google Play, whatever platform you're using to listen to these episodes. And, we take the feedback seriously. We take it at heart, and we try and make adjustments and improvements. Any closing remarks, Purvi, for Parallax and for our audience, and any closing remarks on Barcelona and ESC?
Yeah, no, thank you again for inviting me. I feel like, ESC was like, I always say this, and you're going to laugh at this, but I feel like ESC was Coachella. It's Coachella for cardiology. And it's really this huge medical festival. So I truly enjoyed it. And I really hope that we all, as cardiologists, do a bit of introspection and probably put those defenses, down there and just look at, all this evidence in a probably more in a non-partial way and see, the benefit and risk for our individual patients, because that's the whole point of conducting these multi-million-dollar trials. End of the day, it's our patients that matter. So I have no doubt we all have great intentions. We all may be biased, you, me, anyone out there, but hopefully we have, we clean our lenses time by time to see the clarity on the other side.
Yeah, absolutely. Well, thanks again, Purvi. This has been great. And, for the listeners, thank you for listening and thank you for tuning in every other Monday. FeedSpot actually rated Parallax as the second on the list of 15 best cardiology podcasts that they published in September. So, to the listeners and also to the guests like Dr. Parwani, who've been gracious with their time. Thank you to everyone for making Parallax what it is today. It wouldn't be without the guests and without the listeners. So thanks again, and we'll see you another Monday with another guest.
We hope you enjoyed today's podcast, produced by Radcliffe Cardiology in association with makeadent.org. We aim to bring you a new angle of all things cardiology every second week. Review us on your favourite podcast app or send your comments or questions to podcast@radcliffe-group.com. To view the series, head to radcliffecardiology.com/podcasts/Parallax. Thanks for listening.